about something that's important to us, and that's pulmonary hypertension, so how these two relate. We decided to mix things up a little bit, and I'm going to take a side I may not have normally taken in this debate. I'm going to present to you why treating pulmonary hypertension associated with pulmonary fibrosis is an extraordinarily bad idea. And Dr. Patterson is going to counter me.
He's wrong.
With his thoughts on this particular notion.
I should also say that Amy and the Advanced Lung Disease COE did sanction the 4-ounce gloves for this fight, right? As opposed to the traditional 12-ounce.
Now, do I look like the kind of guy that would use gloves?
Well, thank y'all for having us. We're excited to be here to talk about pulmonary hypertension at a Pulmonary Fibrosis Awareness Day because it just seems that as the years have gone on, this concept of talking about pulmonary hypertension seems to permeate a lot of different discussions in our field. We talk about it in patients with congestive heart failure. We talk about it in patients with pulmonary fibrosis. We talk about it in patients who have neither of those conditions. We talk about it in patients who have blood clots. So we're going to spend a little bit of time talking about the interlap or the intersection or the overlap between pulmonary fibrosis and pulmonary hypertension. And I thought that we'd maybe start just by making sure that everybody knows what pulmonary hypertension is. So pulmonary hypertension, quite simply, is the situation of having high pressures in the lungs. I tell people in the office all the time, the pulmonary blood vessels, the pulmonary arteries are normally a very cool customer. The pressures are low. And the pulmonary arteries have this amazing ability to adapt or to increase their capacitance under circumstances of stress, assuming that the organism is healthy. We typically think about when we exercise.
Craig, these are people, not organisms.
Hey. When we exercise, we may ask our cardiovascular system to increase cardiac output 2, 3, 4, 5, 6 times. And you think about in a situation where you're at your home and you increase the flow of water through your pipes, through your plumbing. You anticipate that if you, say, hook up a hose to the fire hydrant out by the street and hook that up to your main water intake line and turn the fire hydrant on full blast, you're probably going to pressurize the pressures in your house, right? Or the pipes in your house. Well, the pulmonary artery is a little bit different because those pipes in your house have a fixed resistance. They're rigid. They don't adapt. They don't increase their capacitance when flow is increased. Not so the pulmonary artery. Under conditions of stress, the pulmonary artery can increase its capacitance by a degree higher than we can mount a cardiac output increase. And so under conditions of normal physiology, not only does the pressure in our lungs not rise under periods of physical stress or increased cardiac output, it actually decreases. However, various disease states can cause that pressure to be elevated above where it's supposed to be. And we define pulmonary hypertension, or an abnormally high pressure, as a pressure equal to or greater than 25 millimeters of mercury. We also say more specifically that beyond pulmonary hypertension in general, pulmonary arterial hypertension, or what I commonly refer to as a disease of pulmonary blood vessels, also assumes that there's not another secondary cause for that elevation in pulmonary pressure. And most notably, and one of the things that we see most often is a lot of emphasis put on what is the wedge pressure, or a surrogate marker for the left atrial pressure. And we say that in order to have pulmonary arterial hypertension, not only does the pulmonary artery pressure need to be greater than 25, but the wedge pressure needs to be less than or equal to 15. Schizophrenic. As the pressures rise in a state of illness, the elevated pressures and the increased resistance to flow coming out of the right ventricle and through the pulmonary arteries puts an increased strain on the right ventricle, and this is what causes, in a sense, the symptoms that people with pulmonary hypertension develop. The right ventricle, over time, cannot do the work necessary to adequately circulate oxygen-rich blood flow through our bodies. Now, I said that there were many different causes of pulmonary hypertension. And the World Health Organization is a large group that breaks down the different etiologies of pulmonary hypertension into 5 categories. Category 1 is, as I referenced, a disease of pulmonary blood vessels. This is a disease wherein those normally very pliable, very accommodating, very flexible pulmonary arteries become stiff and rigid. potentially in association with other systemic diseases that cause those sorts of molecular changes. So we sometimes talk about connective tissue diseases, which is also a very commonly referenced topic in a crowd talking about pulmonary fibrosis, sometimes medications, and sometimes other diseases. And for the purposes of this discussion, we maybe will contrast a disease of blood vessels with group 3 pulmonary hypertension, which is pulmonary hypertension that arises in patients with chronic respiratory disease. And that chronic respiratory disease could be chronic architectural lung disease, destructions or changes in the normal lung architecture, or situations where there is low oxygen. And we'll talk a little bit later about how states of low oxygen or changes in the pulmonary architecture can lead to elevations in pulmonary blood pressure. So specifically, I want to show you this little schematic here, which is an anatomical representation of the cardiopulmonary circulation. I tell people in the office all the time, if we followed the journey of a single red blood cell after it has dropped off its oxygen supply to, say, a muscle cell, that red blood cell would come back into the venous circulation and would eventually come through the vena cava, come through the right atrium, through the right ventricle, be pumped out through the pulmonary artery, which is the vessel, of course, that connects the right ventricle out to the lungs. That blood would admix with the tiny air sacs, the alveoli, at what we call the alveolar capillary membrane. Oxygen would come onto the red blood cell, carbon dioxide would go out of the blood. That blood would drain back through the pulmonary vein into the left atrium on the other side of the heart, and then be pumped out by the main muscular pumping chamber, the heart, the left ventricle, out into the circulation to deliver that oxygen out to the body. Group 1 pulmonary arterial hypertension is a disease here at the pulmonary arteries. Typically speaking, the changes that lead to pulmonary hypertension in association with chronic respiratory disease are here at the alveolar capillary membrane. So here we have a patient with severe pulmonary fibrosis. I've spent a lot of time talking about blood vessels, but here we have somebody who has architectural lung disease, severe architectural lung disease. How can this scarring, this inflammation in some cases, lead to high pressures? Well, it's really complicated. If the initial insult is interstitial lung disease of any different etiology, some of the changes that we start to see occur include obliteration of blood vessels. All those tiny branches of the pulmonary artery are running out through the spongy lung tissue, which is no longer spongy. It's scarred, it's stiff, it's sclerotic, or people have emphysema in some cases. And where there's destruction of spongy lung tissue, the tiny blood vessels that run through that lung tissue are also destroyed. With vascular obliteration comes changes in pulmonary blood flow. Our bodies are amazing. They have this ability to adapt. And many of the changes that start to occur when people have structural lung disease are very well intentioned to begin with. And the body starts elegantly matching blood flow to airflow to maintain this fine balance to make sure that we get enough oxygen in and enough carbon dioxide out. But these changes potentially can go awry. I don't know if anybody's seen the movie Passengers, which had Chris Pratt and Jennifer Lawrence, but they're on a ship called the Avalon, which is sailing out through space on a 120-year journey, and it's a completely artificial intelligence-oriented machine. And the ship runs into some unexpected trouble early in the journey. The reactor that fuels the ship is damaged, and immediately things start happening in this artificial intelligence world where the ship starts drawing energy from other less important resources to devote to the main power core to keep the ship destined for its destination. Our bodies start to do that. But at some point, things can go so far off the rails that they lead us to new problems that we didn't have before we had the interstitial lung disease. So I'm going to hand off to Chad, and he's going to talk to you a little bit about how often we see this sort of phenomenon.
Okay, so thanks for the movie review and the biology lesson. We're going to move on to something a little more meaningful in terms of how this pulmonary fibrosis and pulmonary hypertension stuff affects people. And namely, the prevalence of pulmonary hypertension and interstitial lung disease is actually, we don't know. The actual prevalence is uncertain. It somewhat depends on the kind of ILD. So is this pulmonary fibrosis? in terms of IPF, or is it in other form in terms of a lung disease or condition related to connective tissue disease, or perhaps pulmonary fibrosis and emphysema, etc. So there's a variability. But looking at pulmonary fibrosis alone, so good old-fashioned IPF, there is some data where they looked at patients who were presenting for lung transplantation. And then 44 of these patients had right heart cath data at initial transplant evaluation. You can see that 38, almost 40% of these patients had pulmonary hypertension. Remember, pulmonary hypertension being defined as mean pulmonary artery pressure greater than 25. Now, in the follow-up, the incidence went up. So these are people that are presenting to a lung transplant center, they're getting worked up for a lung transplant, and then at the time of, or during the follow-up period for transplant eval, it went up to 77%. And in fact, at the time of transplantation, this number is even higher. It's now 86%. So this is something for patients who have pulmonary fibrosis. This is a big deal. It is. It affects a vast number. Now, I think we need to take a minute and think about these are all patients presenting for lung transplantation, so that may skew the data a little bit. So suggesting that perhaps those people that are sick enough with IPF to present for transplantation may be more prone to have this associated pulmonary hypertension. We'll look at some other studies that looked at similar data in terms of right heart cath detected. So this is not echocardiogram, which is often a way that we screen for pulmonary hypertension. This is right heart cath, so this is the gold standard. Your get ranges in other studies reporting anywhere from 20 to 46%. Now, that's not patients necessarily being evaluated or at the time of lung transplantation, but in a lung transplant center. And it suggests that certainly right heart cath picks up more pulmonary hypertension in these patients as opposed to a screening echocardiogram. And again, that's maybe why we're seeing more of these in that population. Why do we care? I mean, so what? Pulmonary fibrosis sucks enough. We don't need another problem, right? I mean, who wants to add on? Well, unfortunately, what we see in pulmonary fibrosis and PH is worse outcome. So patients with pulmonary fibrosis alone, here's data from a chest article looking at 3-year survival. Obviously, this is before the advent of the antifibrotic agents that we have now. But nonetheless, you can see this top line here. Most patients without pulmonary fibrosis, their 3-year survival, most patients with pulmonary fibrosis without pulmonary hypertension, their 3-year survival is not so bad. Well, as the PA pressure goes up, as noted by these checked hash lines, the higher the PA pressure, the worse your outcome. So for patients with PA systolics greater than 50, here at 3 years, their survival is way less than those patients without pulmonary hypertension at all. So the association of the two is a very bad sign for our patients.
It seems pretty clear that we need to do something about that.
Well, I don't know. He's got a good point.
I mean, look at all those hammers.
That's right. In the world of pulmonary arterial hypertension, we have had a golden era starting back in 1995. We had our first drug available for pulmonary arterial hypertension. And you can see the smattering of all these other drugs and drug classes that became available to us to treat pulmonary arterial hypertension. Now, as my esteemed colleague said earlier, pulmonary arterial hypertension being defined as high pulmonary artery pressure, low left-sided pressure, and no lung disease. So these are drugs for PAH. And yeah, there are a lot of hammers, and it makes someone really excited to want to be able to use those tools to treat pulmonary arterial hypertension. Again, pulmonary arterial hypertension, not pulmonary hypertension associated with pulmonary fibrosis. So even though we have lots of hammers and have lots of tools, maybe, as my wife likes to tell me, I shouldn't be doing that. And I want to give you some data as to why this is actually true. Again, here's a list of the variety of pulmonary drugs that we have, two different classes, prostacyclins, IV, and inhaled and in pill form. Endocrine receptor antagonists, these are all pills, phosphodiesters inhibitor, alpha, also known as Viagra, and it's Cialis, and then a drug called Rasuglot, which is a little different, approved for PAH and CTEPH. So lots of tools, lots of hammers. But back to the question: should we be using them? You know, it's kind of like call a professional. Don't do it yourself. And there's data to support this idea that maybe you should call a professional and not use these tools. Here's a study looking at use of sildenafil in advanced pulmonary fibrosis. These are fairly sick IPF patients with diffusion capacities less than 30%. For those of you not familiar, diffusion capacity is kind of a marker of how much lung disease you have. So these are pretty sick IPF patients. So it's a double-blinded randomized controlled trial, so decent scientific evidence. 12 weeks long, decent number of patients, 89 in the treatment group, 90 or so in the placebo. And the primary outcome was, can you walk farther? Can you walk farther at 12 weeks after taking Viagra? And the answer is no. In fact, it did not help these patients at all. Now, they may have been a little more excited if they were men, but otherwise it didn't really do a whole lot to help them walk any farther. Any of the secondary outcomes, DLCO, quality of life, oxygenation didn't really meet statistical significance, but maybe favored using the sildenafil, but it was rather soft. So here's clearly a trial that had no benefit. So BUILD 3 is another trial that randomized controlled trial patients of idiopathic pulmonary fibrosis, the use of bosentan. That's one of our ERAs for pulmonary arterial hypertension. And notice, again, a double-blind, randomized controlled trial, so very robust scientific evidence, healthy number of patients, over 600. Randomized them to get placebo or bosentan. And basically, it showed no difference in all-cause mortality. It showed no difference in time to clinical worsening.
Come on, man. You're missing the most important 3 words on that slide. No reported pH. I'm not talking about using bosentan or medicines like that to treat pulmonary fibrosis. We're talking about pulmonary fibrosis-associated pulmonary hypertension. They didn't even report
I think the title of the study, or the title of our talk, was Pulmonary Fibrosis Associated
Pulmonary Hypertension.
Well, associated blah, 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 blah. No effect on time to clinical worsening or all-cause mortality. Let's look at another study, Artemis IPF. And to respond to your jab, Artemis IPF was looking at ambrisentan and IPF, and it was stopped early due to lack of efficacy. Ambrisentan is much like bosentan, is an ERA that we use for pulmonary arterial hypertension, and it didn't work. But he did make a good point on the last study. He said, well, that BUILD study, that's crap.
At least they tried.
Didn't include pulmonary hypertension. Well,
At least they
Artemis
tried.
PH was geared towards patients with IPF with right heart cath diagnosed pulmonary hypertension. So, in fact, these are the people that you were referring to. And, in fact, it was also stopped early. Why? Because it didn't work. Lack of efficacy in the PH subgroup. Again, pulmonary hypertension being defined by mean pulmonary pressure greater than 25. Again, after 48 weeks of ambrisentan, there was no improvements in hemodynamics. And, again, these people had baseline pulmonary pressures of 30, so higher than those needed to qualify for the diagnosis of pulmonary hypertension. Another study keeps getting better. The study called RISE-IP. This was use of Resealguat in patients with pulmonary hypertension associated with idiopathic interstitial pneumonias. Now, one of those is IPF. As you know, there's others, including NSIP and a variety of other disease states, all causing some type of interstitial lung disease, and one of them being UIP or IPF. Now, Resealguat was one of our newer drugs we had for pulmonary arterial hypertension, and they employed this in this population. So these are patients, again, with interstitial lung disease, some of whom had straight idiopathic pulmonary fibrosis, but there are a smattering of other interstitial processes as well. 145 patients, so decent number. And the primary endpoint was, could you walk farther at 26 weeks? In this study, they also killed early. Why? Because people were dying. It was killed early because there were 17 deaths in the treatment arm versus only 4 in the placebo group. So they'd even go the full 26 weeks, and they had people dying. So the data would suggest to us that our toolbox for pulmonary arterial hypertension is overflowing. Unfortunately, our toolbox for pulmonary hypertension associated with pulmonary fibrosis, maybe these aren't tools. Maybe these are things that might worsen our patients or certainly even hasten their death. So I go back to this slide that Dr. Patterson showed earlier. I stole it from him. That shows why we shouldn't use these drugs in these patients, because you can see all this architectural lung disease. These blood vessels are toast. They are gone. And so these medicines that work on those blood vessels, well, they work on those blood vessels if those blood vessels are there. Those blood vessels are gone. Moreover, we have to be concerned that our body's own mechanisms to deal with this, our body's own mechanisms to shunt blood away from these areas because there ain't no lung there. It's not working. So the body moves blood away from those areas by vasoconstriction. But if we give these medicines that systemically vasodilate our blood vessels in our lungs, that upsets that process. And all of a sudden, we're starting to shove blood back to these areas of lung, which then make oxygenation worse. And in some cases, as the study shows, maybe makes you die. So I would say maybe that toolbox needs to be left on the shelf.
All right. So maybe I got a little overexcited about STEP IPF and Bill 3. Those guys didn't even look at whether the patients had pulmonary hypertension in the context of interstitial lung disease. But you got me with the last couple. They did at least do a subgroup analysis of patients with pulmonary hypertension in the setting of pulmonary fibrosis, and you're right. They didn't show a difference. Maybe it was worse. But you know as well as I do, they didn't ask the right question. What is this pulmonary hypertension? Well, we already saw from the World Health Organization that we've got 5 different categories of problems that can cause pulmonary hypertension. That tells you that pulmonary hypertension in general is a heterogeneous entity. It's not the same in everybody. And I would dare say that pulmonary arterial hypertension is also heterogeneous, even though we're talking about one of 5 different groups of pulmonary hypertensive disease. They're not asking the right question in these studies because, okay, I got you. This is a disease of the pulmonary parenchyma. This isn't primarily a disease of the pulmonary vasculature. But look, Hurricane Harvey, I think we can all agree, is a disease predominantly, or a problem predominantly of water and flooding. But are you telling me that if flooding affects an electrical grid that causes a huge fire that threatens to take out a couple of city blocks, that we shouldn't call in the firefighters to fight the fire because a hurricane is a problem with flooding? Ooh. No. And so, in the spirit of being here at the beginning of the college football season, not so fast, my friend, because what do you do?
Okay, Siskel weatherman.
Hold on. Yes. Hey, you want to talk about tools? I got a big tool chest, okay? I got a lot of skills. What do you do, Chad, when your patient with pulmonary fibrosis has this echo? Because this has gone off the rails. This is no longer a problem with scarring of the pulmonary parenchyma. Look at this right ventricle and look at the left ventricle. We talk about a D-shaped left ventricle, bowing of the intraventricular septum. Let me give everybody who's not familiar with looking at these a little bit of a hint. The right ventricle is not supposed to be bigger than the left ventricle. The right ventricle, for all intents and purposes, is supposed to be sort of a conduit to blood flow. It's supposed to passively go through without much effort. The left ventricle is the big muscular pumping chamber. And here we've got a problem where the right ventricle is crushing the left ventricle out of existence, to use somebody's familiar quote. Here we see an apical 4-chamber view, and again, the structures on the right side of the heart are not supposed to be bigger than the left side. This is the left atrium, which is also being crushed by the right atrium, and the left ventricle is narrowed down to a sliver due to the right ventricle. And this is somebody that I'm telling you has pulmonary fibrosis. But not every patient with pulmonary fibrosis has this. This is somebody who's gone off the rails. So those other folks that you referenced didn't ask the right question. And I'll grant you that treating pulmonary hypertension in every patient with pulmonary fibrosis-associated pulmonary hypertension is probably not a good idea. But because I believe, and I think the data is starting to suggest, that pulmonary hypertension is very heterogeneous in this group, I think we've got to ask, are there subgroups of people who have pulmonary hypertension with pulmonary fibrosis who have gone off the rails and have echoes that look like that maybe we should be doing something about? And it turns out that there's some awfully bright people out there who have asked that very question. So I present for your consideration a trial, a prospective trial of 15 patients. And hey, it's not a lot, but it's a start. And these guys did it right. This is the group out at UCLA led by Rajan Sagar. in consultation with our friend Paul Forfia from up at Temple University. And they looked at all comers referred for lung transplant over a 3-year period at UCLA. And they tried to identify people with pulmonary fibrosis referred for lung transplant who had the most severe forms or manifestations of pulmonary hypertension. These were people who didn't just have a mean PA pressure of 26 or 27 and technically had the disease. These weren't people who had pulmonary hypertension but a normal-looking right ventricle. These were seriously ill patients with the most advanced manifestations of pulmonary hypertension that we ever see. These people had a mean pulmonary artery pressure of at least 35 millimeters of mercury and echocardiographic features of right ventricular failure or dysfunction. So of the 15 patients that they enrolled, they decided, hey, if we're going to do this, we're going to say that these are some of the most ill patients with pulmonary fibrosis and associated pulmonary hypertension. We're going to use our A#1 hammer. Of all those therapies that you listed, we said, hey, these people are sick, we're going to do it right. We're going to use treprostinil, one of the gold standard medications for the treatment of pulmonary vascular disease that may help rescue the right ventricle. Treprostinil, for those who are not familiar, is a prostacyclin analog. It can be administered either intravenously through a continuous intravenous infusion or subcutaneously through a continuous subcutaneous infusion. And so they treated these 15 patients with 14 out of the 15 had subcutaneous treprostinil, 1 had intravenous treprostinil. And I want to show you the characteristics of who these people were to further demonstrate what I'm talking about, that these were patients who were not your standard, oh, I've got a little bit of pulmonary hypertension with my pulmonary fibrosis. These patients, who were give or take 63 years old, had New York Heart Association or WHO functional class 3 or 4 symptoms. These people were profoundly sick, very dyspneic with minimal exertion. About 8 out of the 15 patients had idiopathic pulmonary fibrosis as their particular type of pulmonary fibrosis. There was also a smattering of patients with combined pulmonary fibrosis and emphysema, which is something we see a lot, fibrosing NSIP, and chronic hypersensitivity pneumonitis. And, as if I needed more evidence, you should see that about 60% of the patients who even made it this far before they even got to UCLA were already on pulmonary vasodilators. So that tells you that regardless of all of your fancy schmancy data, people are out there doing it, right? So somebody knows something or thinks they know something that the experts don't know. So what they did is they took baseline measurements of pulmonary function, both by spirometry, lung volumes, and DLCO, and by 6-minute walk test. They also did a baseline assessment of their dyspnea index, or their quality of life, or their symptom scores. And you can see that these were not necessarily, even though these patients were referred for lung transplant evaluation for pulmonary fibrosis, these patients actually had fairly good total lung capacity, of on average about 70%. DLCO was very low, as we often see with pulmonary fibrosis. But these people were hobbled, to say the least. Their average 6-minute walk distance at baseline was 171 meters. They had a resting oxygen saturation of 83% on room air, 98% on a 10-liter face mask. And they treated these patients for 12 weeks. 12 weeks, right? Just a few months with predominantly subcutaneous treprostinil. And you'll notice that the lung function variables really didn't change. Not that we expect to. But look at this. The oxygenation really didn't change. Room air oxygenation was 83% before, 80% after 12 weeks of treprostinil therapy. That wasn't even statistically significant. More importantly is look what happened to the hemodynamic parameters, okay? So keep in mind, these patients did not get any worse from an hypoxemia standpoint, and yet baseline right atrial pressures, again a marker of that the right ventricle and right atrium are struggling, were close to 10. After 12 weeks of therapy, it fell to 6. That was statistically significant. The mean pulmonary artery pressure, this is just astronomical to me, and again highlights how sick these people were. the mean pulmonary artery pressure in this group of patients was 47. They said their entry criteria was it just had to be greater than or equal to 35. These folks were through the roof, and look where we brought it down to, 39, statistically significant. Wedge pressure basically did not change. Cardiac output went up, that's a good thing. Cardiac index went up, that's a good thing. Pulmonary vascular resistance, 700 dynes is just astronomically high. We brought that down to 500 dynes. That's a remarkable improvement over a short period of time. Oxygen delivery, pulmonary capacitance, stroke volume index, pulmonary vascular resistance to systemic vascular resistance ratio, all of these are markers that we look at, and they all were statistically significantly better after just 12 weeks of therapy in treprostinil. So along those lines, I think that we have the sense that pulmonary hypertension and pulmonary fibrosis is not pulmonary hypertension, but there are people who all of those changes that I referenced before that we saw on that busy slide with all the physiological abnormalities that start to occur when patients have architectural lung disease, those changes are very elegant and very well intentioned at the beginning, but in some patients, and perhaps for reasons that we don't understand, those changes take on a life of their own and kind of go off the rails, and the patients start to really suffer. And of patients referred for lung transplant, this probably applied to about somewhere between 10 and 15% of those patients. But these people are really sick, and there's a tangible number of people out there that we could potentially make a difference for. So a group, Sager and others who have been investigating this very thing have tried to, at the most recent World Health Organization Pulmonary Hypertension Symposium in Nice in 2013, tried to propose some sort of a schema or an approach for how we might consider patients who have pulmonary fibrosis and also have pulmonary hypertension. And just in line with what I've been talking about over the course of this entire discussion, we're not talking about getting really excited about treating patients with pulmonary vasodilators in the setting of interstitial lung disease if they don't have pulmonary hypertension, certainly. I'll grant you that. Don't treat those people, right? I'll even give you, hey, pulmonary hypertension, if it's not associated with some of these really morbid features that we've seen, like right ventricular dysfunction or pressure elevations that are through the roof, I'll grant you, don't necessarily worry about treating those patients with pulmonary vasodilator therapy. But consider the group of people who have a truly advanced form of pulmonary hypertension with their pulmonary fibrosis. And the first question that I think providers might ask if they see such a patient is, try to get a sense for what the primary problem is. If the forced vital capacity is greater than or equal to 70%, those are people who, by and large, don't necessarily have truly severe forms of pulmonary fibrosis, and yet if you're seeing them sitting there with aberrant hemodynamics the way we saw, or an echo that looks like what we looked at, consider sending those patients for referral to an expert pulmonary hypertension center, because that's not the same group of people as people who don't have those high-risk features. And if at the same token you're sitting there looking at somebody with pulmonary fibrosis and you see that ugly-looking echo or those deranged hemodynamics, consider that if their lung disease truly is severe, say the forced vital capacity is less than 70%, or maybe a high-resolution CT scan index of disease is really through the roof, probably it's safe to say the first approach ought to be to send those patients for referral at a pulmonary fibrosis center and really make sure that their pulmonary fibrosis is addressed top to bottom before we delve into this other manifestation. Chad, I'll give you the last word. It won't help you, though.
Well, after that, I can say nothing. Although I did have dinner with Rajan Sagar in Frankfurt Airport, and that guy is a whack job. Actually, not completely true. Rajan Sagar is a very bright guy. I did have dinner with him in the Frankfurt Airport. It was terrible, but he's spectacularly brilliant, and we enjoy him as a friend and colleague. So, questions, Dr. Cosgrove?
You've spoken about systemic therapy. What if you were able to deliver therapy to be intact, normal lung by aerosol?
So he makes this very easy because he's a really smart guy, but absolutely, we believe that using inhaled agents in these patients may have some real benefit. And in fact, there's multiple clinical trials ongoing right now. We in our program have used inhaled drugs in these patients for a long time for that very reason, that if I deliver the vasodilator to the lung parenchyma that is normal and working and not the abnormal, do I avoid some of the bad things like worsening oxygenation, et cetera, and improve the blood flow to good lung, which is in fact a great idea. But that's something that we don't have a mountain of evidence for. However, there's 2 active trials that we have ongoing now that are doing that very thing, looking at agents being delivered by inhalation to get around, and hopefully these trials will really kind of help us kind of put a nice kind of framework to this, as opposed to it being a little more of the voodoo that we often practice.
Yeah, and I think heretofore, the limited evidence that we've had, or the limited studies or trials that have been done along those lines, probably just haven't asked the right question, looked at the right subgroup of patients or severity of pulmonary hypertension associated with interstitial lung disease. And so, it's one of those things that it just sure seems like that should work even better than systemic therapy, right? Remains to be seen. I think it's really promising.
The other, I think, to your point, is that would that then be an opportunity for someone beyond or outside of the group that we just kind of defined in our discussion, that says, look, your right heart is bad, your PA pressures are high. Yes, these agents are great. But maybe what about those people that are in between? I showed you multiple studies of patients who didn't have severe PH, didn't have bad right hearts, and the oral drugs didn't do squat. But it certainly stands to reason, and we hope that these agents used in those patients may show some benefit, and that's what these trials now may tell us.
Steve?
Craig, for the modular study, which is very intriguing. Other than cardiovascular, physiologic, hemodynamic measurements, were there any references toward quality of life indicators that these patients were feeling better? I mean, it's a fairly short trial. Do we anticipate that this would carry out?
Yeah, there was that dyspnea index.
Hang on.
If we were treated for a longer period of time, if we would have any sort of survival, because we're too short of a study to really determine.
And that was one of the main comments that they made in their discussion afterwards was, boy, this was really intriguing initial data, but over just a very short period of time. And certainly future directions, it would be intriguing to know whether over a longer period of time, was there a survival benefit. They did mention, and I don't know if they're accurately represented in these tables, here we have the BDI score, but they did follow a couple of respiratory questionnaires, symptom indices, and those did get better in a short period of time. And they speculate that perhaps if given a longer period of time, we might have been able to meaningfully impact survival, but I think that's something that they're keen to eventually investigate on a grander scale.
Do you think that the difference has to do with the use of Remodulin versus Tadalafil, the other?
Well, it's a good question because we don't know what they looked like before, but half of them are on background therapy, which may or may not have been, we don't know. But certainly hemodynamically they got better,
and that's sort of intriguing, is that even with 60% of them being on background oral therapy,
everybody got better.
Those
in a small number.
The average mean arterial pressure in that group, 60% of whom were on background oral vasodilator therapy, was still 47 millimeters of mercury, and the average pulmonary vascular resistance was 700 dynes. And yet, when we took that group and put them on treprostinil, we had marked reductions in both of those variables.
It'd be interesting to know what they looked like before, and I probably should call Rajan and ask him, but I don't know.
But it speaks to this narrative of even in patients with the most severe forms of true pulmonary arterial hypertension, when the chips are down and someone is really sick, we reach for prostacyclin analogs, right? I mean, those are the gold standard agents, prostanoids.
Well, I hope you had as much fun as we did, and thanks for your time.